مساء الخير. Please take your stage. Your seat is ready? Okay. You can sit so as to start our session. Our session is cornea and refractive session. Really, it's my pleasure to sit here among the pioneer of refractive surgery, and I insist to present them now. Definitely, two of them are the speaker and the moderator. They will add something to our knowledge in refractive and cornea. Let us start now with Assistant Professor Zaid Shukr. He's from Al-Kufa, Medical College University of Al-Kufa.
لو يسمحون المودريتورز مداخلة بسيطة. بما أنه hall A, it is the main hall, although it is not fully occupied the seats. بس أحب أعلن أنه كان المفروض البارحة بس نتائج الامتحان الأولي ونتائج الامتحان الكتابي الفاينل نتائجهم امبارحة طلعت و all our candidates they pass. فمبروك للناجحين لأنه يعني هاي نتائجنا احنا بما معناه انه 100% نجاح للفاينل وللبرايمري. طبعا الفاينل امامهم بعد امتحان ثاني اصعب بس good luck. بس حبيت انوه حتى يعرفون انه they are the future of this conference in the coming 4 or 5 years إن شاء الله.
بسم الله الرحمن الرحيم. I would like to thank the committee of the Ibn Haytham 4th Ibn Haytham conference to give me this opportunity to present in between among my colleagues, my friends, and my teachers. My presentation for today is about the invitation to preserve as much tissue as possible of the patient. I have no financial interest beyond this presentation. As you know, or most of you know that our street or our way is not full of flowers. As we live as a shipmaster, sometimes it's windy and stormy, and sometimes the weather is beautiful and peaceful. Anyway, flying is not not an easy job at all, but it's not impossible at the same time. Of course, the team working makes the things better and easier. Our gain is not to get famous and to get prizes at all, but make the patients or people happy and enjoy the nice vision. History. To avoid postoperative complications in keratoplasty such as astigmatism and problems with wound healing, Charles Tillett proposed in 1956 replacing only the back part of the cornea, the posterior lamellar keratoplasty PLK. Gerrit Millis was the initial mind behind the clinical application of endothelial keratoplasty, becoming the first to perform sutureless PLK in 1999. Mark Thierry modified and simplified the technique and creating new tools and describing deep lamellar endothelial keratoplasty in the beginning of the millennium. As you know, here is sometimes unavoidable cases of corneal problems that need just to do PKP with no other possible solutions. These are traditional cases of PKP cases. It's nice anyway, but the question is, do you guarantee that this sequelae of complication will never happen? For example, the first picture with corneal edema, with failed endothelium, early PKPs, advanced PKPs, and corneal haziness and corneal vascularization, peripheral corneal vascularization with cytomal scarring and failed graft? The answer is, of course, no. DISIC, the donor per patient, posed a challenge. In 2006, Mark Grovoy proposed using microkeratome. What really brought DISIC into the mainstream was the preparation of the donor grafts by the eye bank. On the other hand, Dr. Mills published his first paper on DIMIC in 2006, simply by removing the fine and delicate endothelium with its underlying decimus membrane, which is between 15 and 20 microns in thickness. In recent years, conventional penetrating keratoplasty has given way to the new posterior lamellar keratoplasty techniques for selective replacement of the diseased part or diseased layers of the cornea in the patients with endothelial insufficiency. This stripping automated endothelial keratoplasty has established itself as the standard technique worldwide because patients achieve satisfactory visual acuity more quickly than after penetrating keratoplasty and without the changes in refraction. Decimus membrane endothelial keratoplasty between brackets DIMIC is a more demanding surgical technique and can yield functional results much better than those attained with DISIC or penetrating keratoplasty. DIMIC seems to be followed by immune reaction much less frequently than DISIC or penetrating keratoplasty, but the rate of graft failure is usually higher. So we have to weigh between the benefits and risks in choosing which procedure that we can choose. This table can show you some features in comparison between DISIC and DIMIC. Regarding the procedure is easy, or the older procedure is DISIC, and younger procedure or modern procedure is DIMIC, and type of the tissue addition while tissue replacement. And in regard for the increase, the prismatic effect and the hyperopic shift in DISIC is more, while it's neglected in DIMIC, endothelial cell loss. Of course, both are share the same problem, and the availability of the eye banks, prepared donor tissues. In Europe, of course, DIMIC is prepared, while in United States, till now, it's not FDA approved because it cannot be preserved as the normal PKPs or DISIC in Optizol. Rather, it can be just prepared and maintained in tissue culture, while the availabilities in you can do is by standby where we can do DIMIC surgery for DALF surgery for a patient and can prepare the DIMIC membrane for the next patients on this in the side trolley. And the tendency of the donor tissue detachment in DISIC is lower, and it is very high in DIMIC surgery. The rate of visual recovery, it's reciprocal here. It is slower in DISIC, while it's faster in DIMIC. And requires expensive equipments like microkeratomes and Buciniglide, front-loading forceps, all of these expensive and single-use instruments, while it is not needed, just like the ordinary Zeiss, for example, Zeiss insertion glide, that is fair enough. The possibility of the endothelial graft rejection is yes in both. The same thing that we can, if you can, for example, corneal endothelial dysgastritis for endothelial iridocorneal endothelial syndromes on patients with just endothelial cell failure. What we can imagine here is if we have a graft, for example, full thickness penetrating keratoplasty, we have available healthy graft with good endothelial cell counts, and especially if the donor is more than 60 years of age, that I mean the thickness of the decimus membrane is more than the younger age group, we can easily separate, so we can prepare a tissue for another patient at the same time. At least 2 patients will be prepared to serve the vision of them. Sometimes even you can anterior lamellar or citromal keratoplasty for another patient and prepare the demic membrane for the 3rd patient. As you can see here, I have 2 videos to present. This is what we call it PIDIC procedure. This is the last year that I prepared for the first time for me to prepare for demic surgery. This is just like dark surgery, but it's an inverted dark surgery. What we do, insert the bevel toward the endothelium, just in the insertion of the needle, the insulin needle, on the periphery of the cornea, peripheral part of the cornea, and just slowly inject air. And it will, if it's, you can see it is how it is nicely separated, whether it is type 1 or type 2 bubble. It is not important, just to separate the decimus membrane or the predecimus membrane, and then just make a simple puncture to deflate and stain with trypan blue and cut manually. As you can see here, how can we puncture and deflate the demic membrane, and then stain with the trypan blue to delineate easily the grafted tissue to make sure that it is not, the extension will not go to the central part of the tissue. Then proceed to separate it completely and prepare to insertion for the patient in need. And another way, you can see here in the second video, it is manual. I do manual separation by manual separation by tying forceps, for example, just to grasp with the tooth forceps, grasp the sclera, and manual separation by tying forceps. There is a special forceps to do manual separation with a broad end and rounded end with no any sharp ending to avoid rupturing of this delicate membrane. This separation can cause, as you can see here. Then can we do a manual grasping of 2 tying membranes to maintain the intact or integrity of the decimus membrane with the endothelium, and prepared, of course, to the cartilage to be inserted for the patient in need. If you can compare this procedure, I prefer this procedure. It's very easy to do because this failure rate is very low. While in the last procedure, the ordinary procedure, the rupture is very easy and can extend to the center. As you can see here, it's manual separation. It's so easy, but it needs a learning curve. But and for the beginners, I prepare for them just this for easy to do and with no any failure rate, especially even if you fail to do the bubble technique, like the dark surgery. If you cannot do the bubble in the first try, you can do the second trial or third trial. It's very easy then to separate by big bubbling and delineate and cut. You can see here the double folding technique and will be inserted to the cartridge. Let's go to the next slide. I think it's very, we took a lot of time, this slide. This is my first demic procedure. It's in the 2017. This is the first postoperative day after. This is after surgery, about even 16 hours after surgery. Look at we have to do a large air bubble to avoid this early separation of the decimus membrane. And this now is, at that time it was very nice, and it didn't need any rebubbling for the procedure. This is our 4 months, approximately 4 months after the surgery. Till now, the patient is enjoying happy life and without any complications, without any. If you can see or concentrate to the margin, this is much better than the margin, much better than the desic margin. That there is no prismatic effect, there is no hyperopic effect, no any glare during the night. So this is the steps. This is just before the surgery. And this is 3 days post-operatively, the same patient. And for this, this is about 3 weeks post-operatively, and this is the same picture of the last video. This is 4 months post-operatively. So what's next? Balloons, no? Most of you know that our life is full of balloons, no? Yes. Balloons have been used before in medicine a lot of time, for example, in cardiac catheterization and valve replacement and coronary catheterizations. Also in ophthalmology have been used for DCR surgeries, and the double folding will be threatened in such case. How it works? I suppose there is a project, it's my project, to insert the demic membrane by inserting its rolling it on a balloon, small balloon, insert and deflate the balloon. This is a cross section, and this is cross section and longitudinal section. How can imagine that it's easily implanted through to the anterior chamber? But the drawbacks, anybody can ask, the drawbacks is again is this project, is the endothelium touch over the balloon surface. So just cover the balloon surface by viscoelastic before putting the demic membrane on the proposed balloon. So what is the advantage of this balloon project over the enfolding procedure? And the exact direction that we are looking for. The exact direction is first important complication post-demic surgery is upside down, as you know. So the exact direction will be confirmed and guaranteed. The endothelial cells will be maintained from contact and friction with the sides of the glide that is used already in the injection for the ordinary demic surgeries. So we didn't use the glide, so we avoid the friction and the contact of the endothelial surface during its delivery to the anterior chamber, where the endothelial sides direction are out in the heart-shaped demic. As you know, the endothelium is just like a heart shape. So the heart-shaped outway is the outer part is the endothelium, while the inner part is the stromal or dismal membrane side. So in this procedure, we have avoiding or sometimes upside down in the procedure, in the ordinary procedures or demic insertion. This can happen.
Dr. Zaid, please.
Yes.
Just 2 minutes.
Yes,
okay.
Of course. Don't worry. In this balloon implantation, we can avoid upside down of the endothelium by proper implantation of the graft to the and totally attached to its site in the anterior chamber. So, take a home message: the endothelial keratoplasty need a learning curve which must not be drawback against our goals to present the most beneficial services for our patients. So never lose the patient healthy tissue, neither in keratoconus with a healthy endothelium by doing DALK or doing DISIC or DEMIC, at least in patients with pseudophakic or aphakic bullous keratopathy. The early post-operative care is as important as operative technique in hope of a better success rate for endothelial keratoplasty. Still, there is a risk of graft rejection after endothelial keratoplasty, but it is still much better or much less in DEMIC than in DISIC, which is then in turn much less better than in PKPs. And the last of the least, the balloon proposed technique, I hope to get its place in endothelial keratoplasty procedures in the near future, and this will come by our team working and idea exchange among us. Thank you for your listening.
Thank you, Dr. Zaid.
Thank you.